Hi, this is Julie Manoogian from LexMedia with a special episode of Lexington Responds. Today we're going to be going to the emergency room at Massachusetts General Hospital. We'll be talking with Dr. David Brown, who is a Lexington resident, and he's also the chief of emergency medicine.
Well, good afternoon. Thanks for having me.
Tell us where you are zooming from right now.
I'm actually in Trauma Bay 1, one of our resuscitation rooms in the emergency department, in the acute area of the emergency department.
We're all curious about the volume of COVID patients that you have there. Are you seeing a surge right now?
We're actually past the surge. Our surge was in the last 2 weeks of April. We peaked about 10 days ago, and each day we are seeing slightly fewer patients with COVID, although certainly still lots of patients with COVID, pneumonia, and severe respiratory illness.
And how is your staff and your colleagues holding up? Have they experienced any significant illnesses?
The staff's been incredible. Emergency medicine is a team sport, and it's never been more evident than during the response to the COVID pandemic. Our providers have done incredibly well responding to the needs of our community. I'm really proud of that. So far, in terms of their health, in addition to their great morale, their health has been really good. We've been fortunate that we've had no physicians or frontline nurses infected with COVID as yet. And although we have had some colleagues in the department infected, all of those have recovered or are recovering, and many are back to work.
So we've seen a lot in the news about the low supply of masks and PPE. How do you feel your staff is supplied?
So that's a great question. It's been an important issue and a challenge across the world and around the country. Fortunately, here at Mass General, we've actually been planning and preparing for this sort of emergency for not just a few months, but really years, starting back when we started our Center for Disaster Medicine in the aftermath of the Boston Marathon bombing. And because of that, we've actually been relatively well supplied with PPE really from the beginning. And I think that's contributed a great deal to the good fortune we've had with our frontline providers staying relatively healthy during the response to the pandemic.
So as chief of emergency medicine of the largest hospital in Massachusetts, what is your most important goal or responsibility every day?
Well, I would say that during the surge, my major goals or my major concerns were, would we be able to meet the needs of our community? Would we be able to provide the type of care that all patients who needed it at the peak of the surge? The answer to that has been yes, now that we've crested the peak. The other important thing that I've worried about is, would we be able to keep our healthcare providers safe and healthy during that process? The answer to that has also been yes, which has been terrific. I'd say that my concerns have now shifted to some other things, which include the health equity issues that the pandemic has highlighted, things we were already aware of, but have become accentuated or underscored during the pandemic, and that is that our economically disadvantaged communities have borne the brunt of the pandemic. That's been extremely visible here in the emergency department at Mass General, where we take care of our neighbors in Chelsea and East Boston, Revere, and other communities near the hospital. The other thing that is front of mind now is, how do we start to provide the type of health care that people need across the spectrum of illness and injury, not just the COVID response, because some very important health care has been delayed during the COVID response, and we need to get back to providing that.
And with COVID, are you seeing a certain population that's more susceptible to getting it? We're hearing a lot about race and age and maybe even blood type.
First, you're more susceptible if you live in relatively crowded conditions, if you haven't been able to socially isolate, if your job requires you to come in contact with other people and you haven't been able to work from home. As far as the phenotype of people who've been most affected by the illness once contracted, COVID-19 clearly has a tropism for older patients. Older patients have much more severe illness and are much higher death rates. In addition, patients who have pre-existing lung disease or other immunologic diseases that would impair their ability to have a normal immune response are likely to have more severe illness. I'd say the other two groups that stand out from my own experience are patients with diabetes and those with morbid obesity.
So let's talk about antibody testing. This week, MGH announced a study of antibody testing for 1,000 Bostonians. Can you explain antibodies to us and how they relate to another term we're hearing about, which is herd immunity?
Sure. Antibody testing is important for lots of reasons. Once we have established good IgG antibody tests that are specific for SARS-CoV-2, which is the virus that causes COVID-19, we can then use antibody testing to understand the prevalence of disease in a community. We can use antibody testing to help guide return to work guidelines. We can use antibody testing to help monitor responses to vaccine trials and a host of other important things. But specifically as it relates to herd immunity and the question you asked me, Mass General has been doing antibody testing in the community, first in Chelsea and now, as you mentioned, in parts of Boston, looking at asymptomatic populations and trying to understand the degree of antibody prevalence specific for SARS-CoV-2 in the community among patients who are asymptomatic. And once we have a better understanding of the degree of asymptomatic spread of this virus, we will have a better sense of how long it will take us to get to the concept of herd immunity. Herd immunity occurs when 65% or so of the population has developed antibodies, protective antibodies to an antigen, in this case, SARS-CoV-2. When that happens, even the people who are not protected by antibody in prior exposure have a much smaller likelihood of becoming infected because they have a much smaller likelihood of coming in contact with anyone who has the virus. So understanding the degree of asymptomatic spread is critically important to understanding how long it will take us to get to herd immunity before such time as there is an effective vaccine.
And beside COVID cases, is your emergency room busy with patients with other illnesses?
This is actually a problem. We're not as busy as we've been. In fact, across the country, emergency department visits have cratered during the pandemic, down between 40 and 50%. I think patients are mostly afraid of coming to the emergency department. They think maybe they'll contract COVID here. That's actually not true and not something to be concerned about. We haven't had any patients contract the illness while they've been in the department. But nonetheless, patients are worried, and so they're staying home. For some conditions, that's probably okay. For very low acuity visits, finding other sites of care for low acuity visits makes sense and is reasonable. But what concerns me the most is that we've seen a marked reduction in patients with acute cardiovascular diseases, including heart attacks, acute strokes, and intra-abdominal infection and emergencies. Those are all diseases and conditions that don't take a vacation just because there's a pandemic. And the fact that we're seeing about 30% less in each of those categories concerns me because I believe that those patients are riding those diseases out at home untreated. Many of them, actually all of them, have time-sensitive treatments that would reduce morbidity and mortality. Yet if the patients are staying at home, they're not going to get those treatments. And as a result, they're going to have more disease burden and more illness and more mortality. And I would just point out that the mortality related to stroke or sepsis or myocardial infarction is actually much higher than the mortality related to COVID. And on top of that, untreated stroke, sepsis, and myocardial infarction has an even higher mortality rate.
So people should not be afraid to come to the hospital.
Yeah, just to reemphasize, people should not be concerned about coming to the emergency department if they have emergency symptoms. We're here for the community. It's our job to serve, and we're ready. We have capacity, and we don't want patients riding out strokes and heart attacks and abdominal complaints at home untreated. That would be more dangerous actually for the individual than a COVID infection would be.
So if you don't mind giving us an overview of exactly what is COVID, how is it spread, and how can we protect ourselves?
Sure. So COVID-19 is the disease process caused by the virus, the novel coronavirus SARS-CoV-2. It's novel because it moved from a different species to humans, so there's no native immunity in humans, which means we're all susceptible. Most people who are infected with SARS-CoV-2 will have mild illness, mild by my standards. Remember, I'm an emergency physician. A significant minority of people will have GI symptoms, diarrhea, abdominal crampy pain, and in a small number of people, that will be their only set of symptoms. But most people will have those symptoms, and then those will be pretty mild. About 85% of symptomatic patients will recover without needing any intervention except for Tylenol and rest and fluids. About 15% or so of people who become symptomatic will need hospital-based therapies, oxygen, hydration. Most of those will need admission. And about 40% of those will need admission to an intensive care unit, will need ventilatory support with oxygen delivered through a ventilator. In terms of how we get COVID-19, transmission is primarily through droplets. So an infected individual could cough or sneeze or speak loudly and spray into the air lots of little droplets of moisture out of their nose and mouth. If that person's infected, those droplets contain virus, and if you inhale those droplets, you can become infected with COVID-19. Alternatively, that person who's infected can sneeze or cough, and the droplets will land in a more or less a 6-foot radius onto surfaces. And if you put your hand down on the surface and then put your hand on your face, which we do all the time and is hard to avoid, you can self-inoculate yourself with COVID-19.
So masks then are very important because we want to cover the area where we're sneezing or talking loudly.
Absolutely. Masks are a major part of the prevention campaign, the social distancing campaign, and I'm fully supportive of wearing a mask every time you're out in public, not just here in the emergency department, but when I walk home, I wear a mask. When I take a walk outside, I wear a mask. When I visit a family, I wear a mask. And the reason for that is that the mask keeps those little moisture particles that emanate from the nose and mouth during a cough or a sneeze or even a loud voice statement. They capture them inside the mask, and they prevent me, if I happen to be infected, from infecting anybody else. So really, we're wearing masks to be good neighbors. And at this point in time, it's really important to be good neighbors.
Yes, it is. So for those that have lost their lives to COVID, can you explain to us how does the disease become fatal?
Sure. So as I said, most people will have mild illness. Of the people who develop symptoms, about 15% will end up in the hospital, and about 40% of those will end up in the ICU, and about 1% of all people who become symptomatic will die. In those cases, the most common cause of mortality is the development of severe hypoxemic respiratory failure, which means inability to oxygenate the blood, and the development of a condition called acute respiratory distress syndrome, or ARDS. It is not known exactly why some small but significant percentage of people infected with SARS-CoV-2 develop ARDS, but what does seem clear is that there is an overly vigorous immune response in those patients, so that the presence of infection plus an overly vigorous immune response, a so-called cytokine storm of inflammatory proteins that are released during any infection, together contribute to the destruction of the lung architecture and the development of ARDS. And in patients who develop ARDS, we know from large-scale other trials from other conditions that the mortality rate is going to be about 30%. So in patients who end up in the ICU, remember that's 40% of about 10 or 15% of all people who become symptomatic. About a third of those will be expected to die, even with great critical care and novel treatment.
So what safety messages do you have for us? Hearing it straight from you, the Chief of Emergency Medicine, what should we be doing?
The messages are the same. Stay home as much as you can. Stay away from other people as much as you can. Wear a mask when you're out in public. Wash your hands with soap and water. When you don't have access to soap and water, wash your hands with an alcohol-based product. If you get sick, isolate yourself as best you can away from people around you. And share those best practices with everybody around you and encourage other people to do the same. We ourselves, if we are young and healthy, may not have much of a risk from COVID ourselves, but each of us has older people in our lives that we care about, or people with chronic underlying lung disease that we care about. And if we infect them, their risk of mortality will be much higher than our own. So again, it comes down to being a good neighbor.
So Dr. Brown, you've moved. Now where are you?
Now I'm in my office here at Mass General.
Excellent. So now we can take some time to just talk a little bit personally. So I read that you came to MGH 30 years ago. You were originally going to be an internist and then changed paths to go into emergency medicine. In your 30 years, have you ever seen anything like this?
I don't think any healthcare provider has seen anything like this. This is unprecedented. The demands on the healthcare system during the COVID pandemic are unprecedented. I've certainly never seen anything like it. I would add, though, that those of us who choose emergency medicine, for us, serving during something like this, a crisis like this, where our community needs us, that's why we went into the field. I consider it an honor and a privilege to lead this department at this time when our community has its greatest need, the healthcare need of certainly my career. So it's a terrible thing, of course, for society. But for me, it is a privilege to serve in this way.
Well, that's very honorable. I'm sure you were also there during the marathon bombing of 2013.
Marathon bombing in 2013 was really a seminal event for us in disaster preparedness at Mass General. I think you'll remember that although it was a terrible, terrible tragedy and it struck at the core of Boston and Bostonians, that no patient who was brought to a hospital alive subsequently died. And we were proud of that, but we also realized in some ways that we had gotten lucky and that we weren't adequately prepared for a large-scale disaster. And what I mean by getting lucky is that the bombs went off just before 3 p.m. So each emergency department had both the day shift and the evening shift on site. So we were effectively double-staffed. In addition, the bombings occurred geographically in the center of Boston, and there were EMS leaders on site who could direct patients to hospitals in a way that one hospital wouldn't get overwhelmed. So we recognized that although we had served our community collectively really well in the aftermath of the bombing, that we were not as prepared as we could have been. And in that year, we established here at Mass General in the Department of Emergency Medicine, the Center for Disaster Medicine. And it's that center that has been really preparing, planning, studying, training, leading training here at Mass General across our healthcare system and really across the region for 7 years now in preparation for exactly this sort of event. So we are much more prepared this time around than we were in 2013. And
I understand you are captain of the team, of the marathon team.
I think that kind of overstates my role. Mass General has some charity runners, charity teams, and one of those is for emergency response. And yes, I serve as the captain of that team, which means that I'm the principal cheerleader and loudest supporter on the sidelines of the marathon. We look forward to getting the marathon going again, hopefully this fall, if not, then in 2021.
Oh, yes, that's what we're hoping for, too. So speaking of athletics and sports, you also have another very exciting job in the sports world. Tell us about that role.
It's a small job, actually, but a fun one. Mass General Sports Medicine provides medical care to a number of the Boston area teams. And Mass General Emergency Medicine provides the emergency coverage for both the Bruins and the Patriots. And I've actually been involved with the Patriots for a really long time, more than 20 years, and it's been an incredible experience.
Have you been able to go to any Super Bowls?
I've gone to a lot of Super Bowls, yes.
Well, you're very lucky. So at this time, are you seeing a lot of generosity and kindness of the human spirit?
The outpouring of support, both for me personally, from friends and family, and even more importantly, the outpouring of support from our community at large for the work that our hospital and all healthcare providers are doing during the pandemic to support and serve our community has been unbelievable. Food has poured into Mass General and other hospitals as measures of support, and the messages that I see left on the sides of buildings and in windows really elevates our spirits and makes us feel like we're all in this together. It's that type of support is really greatly appreciated.
Do you have any prediction for us based on all your experience when you think we're going to be out of the woods?
That's the million-dollar question. We need to, in a thoughtful way, start to open up society again, while at the same time having ways to have community-based and equitably distributed testing surveillance so that we know when infections start to pick up again, which they will, and so that we can manage those infections as they come, as they start to develop again with the relaxing of the social distancing policies. I'm not sure what normal looks like in the future. It's going to be different than the pre-COVID normal, but I'm confident that together we'll get there.
And do you agree with these concerns that we might have a surge again in the fall?
Well, as we relax physical distancing policies and people start coming together again, the likelihood of transmission of the virus will start to go up. I don't think it'll be as strong of a surge as we saw during the past 8 weeks, because the period of time leading to that surge, we didn't really understand social distancing. We weren't wearing masks. We weren't sitting 6 feet apart. We weren't washing our hands as religiously. All of that should be in place as we relax physical distancing policies, and that should slow the spread of the virus during the next phase. And so while I do expect there to be ongoing transmission of disease, it is my hope that we will not have the type of surge that we experienced in March and April.
So let's end on a lighter note. You're a Lexington resident, and many of us know your wife, Deborah Brown. She is the moderator of our town meeting. So one of my questions for you, when I think about you, your family, I know you have 2 children that went through Lexington High School. How do you protect your family?
So I visit, I wear a mask, I sit 6 feet apart. I hope to do that again tomorrow, Saturday.
How do Dr. and Mrs. Brown de-stress? And what are some of the things you are looking forward to doing when Lexington reopens?
Well, there's a lot of great things in Lexington. I'd say that right now, the way we de-stress is we sit in our garden. We watch our beehives with lots of activity. We watch our chickens scratch in the dirt, and we catch up on the week's activities. I'd say one of the things that I'm looking forward to when COVID is largely in the rearview mirror, I'm really looking forward to being able to attend a Lexington Symphony concert. The Lexington Symphony is an unbelievable gem. For a town like Lexington to have its own symphony is really incredible, and I enjoy going to virtually all the concerts, and have been amazed at the talent of the musicians and the richness it adds to our community.
I agree. We love, at LexMedia, we love filming the Lexington Symphony. Well, Dr. Brown, thank you for taking all of this time with us. Your community appreciates that you're giving us this inside access to you and to the emergency room. We know you're very busy. We wish you continued good health to you and your staff. And we can't wait to see you walking around Lexington with Mrs. Brown very soon.
That would be great. Thank you very much. Bye-bye.
Bye-bye.